about this. So it's the level of the injury, and the other thing that you need to think about, and this is critical for practice, and this is also critical for this test. There is, now, when we talked about shock, we did not mention spinal shock. It is a thing, but it does not play into the groups because it kind of goes away. Neurogenic shock doesn't really go away. After the swelling of the cord goes down, if it's not completely transected, you will get back some of your stuff. Neurogenic shock has all that bradycardia and all the things, right? Spinal shock is complete, flaccid, below the level of injury. Does that sound anything like neurogenic shock? Bradycardia, hypotension, temperature differences, warm, dry. That does not sound. Flaccid paralysis is not neurogenic shock. Don't get in the weeds. The second you see flaccid spinal, that's it. Folks got so confused. Flaccid. PEA. No pulse. I don't care if it looks like rainbows and unicorns. PEA. That's it. Seven cervical, 12 thoracic, 5 lumbar, 5 sacral, 4 coccyx that are fused. We already said, based on where the injury is. Flaccid paralysis. Depending on where the injury is, depends on the motor function, loss of sensation, pain, touch. What is proprioception? It is positioning in response to what? Where everything is. So I know he's sitting here. If my proprioception is all, like I'm just going to come and fall on him. And also, I know where the edge of the building is, right? Ah! That's what keeps us, not so much with me because I broke my toe when I stopped it. But I still know where stuff is. Everybody stumped their toes in the later. You might have bowel and bladder dysfunction. You might pee too much, or you might not pee at all. Spasticity. What does that mean? Muscle contraction. Yep. If you don't move muscles for long enough, what happens? Once they get contractures, that doesn't go back. If you try to straighten out a contracture of a limb, you will break bones. Don't do that. Once it is contracted, that's it. It stays that way. Your assessment. Airway, 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 especially if you're thinking it is a cervical injury. C2, 3, 4, and 5 keeps you alive. Why am I talking about a jaw thrust? How do we normally open your airway? Do I want to do this? No. No. If you have not been trained in a jaw thrust, please don't try this. You actually put your hands back here and pull, and guys, this hurts. Don't try this on your conscious loved ones. Hey, come here, baby, let me try this. It's going to hurt. You actually take their jaw and pull it forward. Yeah. And you need 2 people. You can't pull this forward and back. It don't work. This is for trauma patients. If I have to choose between head tilt, chin lift, and keeping your airway open and jaw thrust and not, what am I going to choose? I've got to do what I've got to do to bag them. You've got to protect that airway. So, is our diaphragm important for breathing?
Yes.
You can't breathe without it. Guess where the nerve is that innervates the diaphragm?
I don't know where it is, but I know it's the phrenic nerve.
It's at C3, 4, and 5. If you have a spinal injury there, guess what they don't do? They don't breathe. After about 5 minutes, you have a dead patient. If that is injured, they need immediate, what? Intubation, mechanical ventilation. Cervical immobilization, never before airway, never. So, if you get to, you're doing your assessment, and airway's fine, breathing's fine, and they're bradycardic hypotension, what kind of shock? Neurogenic. I didn't say nothing about flaccid paralysis, did I? What is an, yes, we're going to say what's your name, all that. What is a neuro assessment? Yes, you're going to do GCS for a spinal cord injury. It's a little different. Squeeze my hands, move this. Now, when I did the neuro check earlier, I said squeeze my hand, move your feet. This one might be a little bit more involved. Can you lift your arms? Can you lift your legs? I didn't just do the push the gas and pull up against my hand. Sometimes they might be able to what? Lift one and not the other. I might even ask them what? Can you shrug your shoulders? If they ain't breathing, y'all don't do that. Guys, we don't check reflex. I mean, if you want to check reflexes, you just go right ahead. If it's an emergency, please don't check their reflexes. How do we check sensory? Get them to close their eyes. Don't let them cheat. Why am I worried about GI and GU? Like a bad trauma patient, if y'all have ever been in there, the doctor sooner or later is going to do what? He's going to put some KY on his finger. We call it the Devandy handshake. And he is going to check rectal tone. If he sticks his finger in there and there is nothing, that's a really, really, really bad sign. There is no sphincter tone. That's a spinal reflex. There's another, this is a really bad sign of a spinal injury. Also, in young men, does anybody know what it is? Priapism. I have seen it once. A young man at a clandestine rodeo. He got thrown and he cornered his back. The metal, yeah, it hurt me. And I showed up and he had a priapism. I flew him out. That is a hallmark sign, spinal injury. He couldn't move his legs either. Here's the two things about interventions. You immobilize and stabilize. Cervical collar. Guys, your initial assessment, your primary and secondary doesn't change. It's always airway, breathing, and circulation, unless they've got a catastrophic bleed. Vital signs, pain assessment. You need to monitor for signs and symptoms of complications. You're still going to do that CT. What is this? And since 1998, this has probably been sexy and not sexy about 15 different times. We're going to give them high-dose steroids. Oh, that's a horrible idea. Oh, we're going to give high-dose steroids. Oh, that's a horrible... I'm like, y'all need to just either get on the wagon or get off. Either it's a horrible idea or it's not. You might see them give them steroids, you might not. Fluids, vasopressors, analgesics. Not just to seek all of it. Yes, ma'am.
So like, would they be feeling pain if it's a severe enough, or would they not? Like, say they have like another injury of their leg, would they be able to feel that per se?
So, here's a weird thing. So, when I was in paramedic clinicals, we were trying to get this guy out of the car. And when you're out there with big burly firefighters, men and women, and you're the smallest person, you get to crawl in the car. And when they break glass, you cover yourself with a blanket. And I'm trying to start an IV, and then we tried to pull the patient out. So I'm at every wrong angle, and I pulled on the patient, and I felt the disc when it herniated. So I crawled out of the car and threw up, and they got the patient out. And it's still numb. Like, I never got it back. Like, it's numb. If you touch that, and like, it hurts so, that don't make no sense. I can't, like if you really push, I've got deep breath. Why does it hurt? Like, we gonna fight. It hurts so bad. And I've talked to other people that have had a stroke that is like, why? Why does it hurt if it's numb? So I really can't answer that question. Because that was in 2000. So I don't know, because it's an old injury. In the acute phase, maybe? Because it wasn't always numb. That developed. What is a safety thing with that if I can't move that leg? Pressure sores. You finna run me out the room. What do the patients always do? Can I control that now? You ain't noticed that my leg's hanging off the bed. And you finna go out the door. Yep. You finna go out the door. And my leg's hanging off the bed. What's finna happen? You gonna break that?
Call it.
Yeah, you better call ortho real quick. How my daddy get his leg broke? Well, what had happened was cervical spine. What kind of paralysis are we talking here? They don't have any movement, right? None. Can't move. Below C1, C2, and C3, immediate intubation. They're gonna die. That phrenic nerve is gone. It is life-threatening. They cannot move any of their limbs. C3, 4, and 5 keeps the diaphragm alive. If it's lower down, they talked about maybe having something here, like in the shoulders. That's not important. I want you to remember this, and that it is a absolute life-threatening emergency because it affects what? Diaphragm, and therefore airway and breathing. I cannot so if you had somebody that was in this happens a lot when? What kind of accidents? During the summer. Motorcycle and diving. Here, hold my beer, y'all watch this. We're gonna do the twilight jump from the top of the 5,000, 1,500 feet rock, and I shouldn't have dove from that, and there's a rock shelf down there, and I hit my head, and I have the fracture at C2. Respiratory failure. We're going to talk about autonomic dysreflexia. Guys, I've only seen this once, and it scared me bad enough. It gave me PTSD forever. Like, I looking forward to any patient that don't even have a spinal injury. You got it? No, I'm just kidding. they can still go into neurogenic shock. I'm not gonna give you a question like that. They can't, I'm not gonna give you one that got both. Don't even look at that, never mind. Nothing. What is your thoracic spine control? Your trunk, legs. You're gonna have a leaky bladder. What's this? My young ladies. I couldn't put a picture of this on the slide, I might get in trouble. What might it affect for my young men? All your reproductive organs. Besides your physical health, what are we gonna have to consider? Their chances of having a family just went out the door, right? Maybe not. I'm not saying it always goes away. And there are other ways to have a child. If the man can't get an erection, they can go in and harvest his sperm, but these people need psychological counseling because their life has changed on a dime. It does affect the trunk. Usually it is paraplegia, both legs, pelvic organs. This is critical. Usually an injury around T6, this is important, is where that autonomic dysreflexia comes in. Not so much T7 to T12. What happened? Broke. So T6 and above, this is life-threatening if you don't figure it out. The higher the level, especially if you start getting into the cervical spine, here we go again. What are we going to get into? You're going to impact the respiratory function. Why do I keep putting that? You guys have to know the difference. Maybe that's why I kept putting it. Between neurogenic shock and spinal shock. Flaccid paralysis. All the signs and symptoms of neurogenic shock that we've talked about and beat that dead horse. Spinal cord injury above T6. And I know that some of this sounds a little stupid. What does the word noxious mean? If somebody is obnoxious, they get on your last nerve. And you might not think that this is a noxious stimuli. What causes this? What is a noxious stimuli in this case?
Like you talking.
A belt tight and closed, a string, your bladder, and they can't pee. My young gentleman, a tie. What else? Yours doesn't have one. The string on her hood, maybe a tag. Something is compressing on these people. Guess what? They don't know it. All they know is that they feel awful. Severe. This is important. Autonomic dysreflexia is tested a lot on the NCLEX. Severe hypertension. These are hallmark signs. 300 systolic. What is this going to cause? Stroke. Throbbing headache. Now, is this the worst headache of my life? No. That's not how they describe it. Bradycardia, low heart rate. Autonomic dysreflexia. It's all out of whack. Bradycardia, facial flushing. I don't know why the nasal congestion, but it truly is a thing. So, these are important for the test. You might get all, you might get 3 or how many are there? You might get 3. You've got to figure out what. If you had somebody that had a T4 injury and you walk in and their blood pressure is 270 over 120, what am I fixing to start? You're going to be naked by the time I get done. I'm serious. If you got a belt on, it's coming off. If you don't figure out what's wrong, what if you had a Foley? What am I? Track that all the way back up there. What if it's got one of the wheels of the bed on it? And what's happening? It's backing right up, and what's it doing to the bladder? How do you fix that? Yeet the bag out from under the wheel. Guys, it stops once you remove that noxious stimuli. And it's pretty freaking scary when their blood pressure is that high and you have no idea what's wrong. And you ain't never worked on the neuro floor, and you just up there doing your clinicals, minding your own business. I had to go sit down for a minute. Where's the number one area that nurses hurt their back? How do we do it? And using poor ergonomics, body mechanics. The population is just getting bigger. Y'all, this is a time to admit you need help. Don't go in there trying to pull this patient by yourself. I'm going to be standing right there when I get pushed the patient up there, and until you come down there and help me, I'm still going to be standing there. I got 12 hours. I might be sitting when you come down there. I'm not hurting myself. Lumbar spine. Now this might just be weakness. Why do I have the bladder there? Do you guys know when it turns into an emergency? When I herniated that disc, it was L4, L5. They told me if you lose control of your bowel, you need to go to the emergency room, because that means what? It's now pressing on the cord. That constitutes an emergency. It might just be a weakness. So I didn't want surgery. I was 27. And I told the neurosurgeon, I said, I don't want surgery. A year later, he said, you have 2 choices. You can either get surgery or you're developing drop foot. When you want to do it, he said a week from now. So December the 21st, and I was back on the ambulance 7 days later. Stupid. L1, L2. Where's the normal place that we fracture it? L4, L5, S1. I don't know why I always thought that the disc was like solid. Guys, it's like a jelly. And when you herniate it, it kind of comes out. And what runs out the sides? The nerves. That's what hurts. Is because what? The bones crush down on those nerves. How do they know which nerves are being pressed on? Symptoms. Who said it? Dermatomes. There is a map. And if you looked it up online, and you can draw this area, and it is innervated by the nerves at C5, C6. The bottom of your foot is L5. When I injured that, I'm like, why is my foot numb? And it is exact to a point. Spinal shock, autonomic dysreflexia, neurogenic shock. Here's the difference. Spinal shock is just a peripheral neurons become temporarily unresponsive. That's just gone. It's vasodilation. Flaccid paralysis. Guys, I'm not going to make this question hard because neuro, to me, is hard to understand. Not ICP. I got that. Spinal cord is a little bit difficult to understand. Does everybody know where your bladder is? Right in here. And I don't know if y'all have ever seen somebody whose bladder is distended. You can see it. If you walk in and somebody had a diving injury and a T5 and their blood pressure is that high, there is nothing wrong with going over and feeling. Palpate the bladder. Check the Foley for kinks. Why this? What might they have? An obstruction or impaction. The first two things I'm going to do is feel that bladder and look for what? Look for that clothing, belts, ties, even like, y'all ever had elastic pants that they were like way too tight? So these are little marks when you take it off. The first thing I'm going to do is give them blood pressure meds, right? No, it's not going to stop the problem. I've got to figure out what is triggering this. I've got to get rid of the stimuli. You can give blood pressure meds all you want to, it ain't going to bring that blood pressure down. You're just going to let them die. Full bladder, restrictive clothing, the socks, why? The elastic on the socks. I told you, they get naked. Even, what about the underwear? The elastic, naked. Dude, they're going to walk in and be like, don't judge me. How about this? What if they've been laying there for 6 hours in one spot? It's a noxious stimuli, right? I don't want to lay there for 6 hours in one spot. Flushed face, headache, sweating, and what was it? Nasal congestion. T6 and above. I told you this is not a lot. I need you to focus on the level of the injury. C1 to like C5, what's priority? Breathing and airway, always. Thoracic, especially above T6, autonomic dysreflexia. If you're talking about the lumbar, you always need to do a bladder and bowel assessment to make sure that you haven't lost that and it's become an emergency. If you're talking about spinal versus neurogenic shock, flaccid paralysis, neurogenic shock, if you want to look back at that slide, it's bradycardia, not pale, cool, clammy skin. It's going to be warm and dry, and hypotension. Autonomic dysreflexia, remove the noxious stimuli, then you might give blood pressure meds. You are not going to give those meds first. It's not going to stop the problem. Your patient's going to die while you're trying to give them medication. You ain't going to get it out of the Pyxis.
Oh, your patient's on the floor, unconscious and dead.